Good afternoon, Dr. David Johnson's my name. Thank you for the opportunity to present this lecture on a subject that I'm very passionate about, back pain, its optimal management and of course optimal and fair compensation for those who are suffering from it. My passion for educating about back pain grows as I see persisting, if not increasing, misinterpretation of the huge amount of data that exists on this very bland but highly prevalent condition. A brief slide about my clinical experience. I still remain in full-time clinical and surgical practice, primarily at the Brisbane Private Hospital and St Andrew's War Memorial Hospital in the city. This year is the first year, however, that I'm going to have at least one dedicated medico-legal consulting day per week, and I'd be delighted to help with your spine injury clients. Most of my private practice career has focused around developing services for spine-related pain. This includes multidisciplinary clinics, rehabilitation services, regular community seminars, and of course surgery for those unfortunate patients that don't receive optimal treatment for their spine pain in a timely manner and that have structural compromise beyond the ability of natural healing. Now, the most important point here is that back pain is not a diagnosis. It is a symptom, and any medico-legal report or clinical report that uses the term back pain interchangeably as both symptom and diagnosis is fundamentally flawed, and the conclusions drawn are likely to be very misleading. Non-specific low back pain, mechanical low back pain, lumbar strain injury. These are commonly used terms reflective of a poor understanding of the pathomechanisms resulting in low back pain. And it's like me labelling someone in a medico-legal report as suffering from headache syndrome or shortness of breath syndrome. It's really not very helpful. And furthermore, these terms such as degenerative low back pain or lumbar spondylosis is like me ascribing pain and disability simply to the normal pain-free process of aging. That means we would have to think that wrinkles and grey hair cause pain because that's a normal part of aging as well. And the spine is no different. It is allowed to age. That is a normal physiological process. It should not be painful. A tiny minority of back pain symptoms are due to recognised primary diseases such as spondylolisthesis, infection, cancer, autoimmune arthropathy, or overt trauma that is causing structural instability. Those are the minority of presentations of back pain. So this is the National Burden of Disease Study, published very recently, August of last year. Now, back pain is second only to heart disease and cancer in terms of disability adjusted life years and total burden of disease. And even more alarming is that when we compare the results of back pain burden in 2003 compared to 2018, back pain problems are increasing, whereas at least we are making some progress with coronary heart disease, which is decreasing. So we know that there are several million Australian adults with back pain right now. Many will meet the criteria of chronic pain, and these people are not confined to the older age brackets. We have abundant services within the back pain therapeutic industry, and this poses provoking questions, most significant of which is reflecting on our own performance and concluding that the back pain industry itself may be to blame for maintaining a suboptimal treatment methodology. Now, all conditions that are prevalent or ubiquitous have a common, recurring and generally clear causation. They are not perfect storms when everything must line up precisely for them to occur. Every disease that is effectively managed has a robust working clinical model. Here's an example of a clinical model for cardiovascular symptoms. There's a causation and there's a effect in the symptoms that evolve. And likewise, with back pain, we must create a model, a causation-based model that explains the symptoms of back pain. Back pain is everywhere. There must be a cause. My spine pain practice is based on a causation clinical model centered around movement dysfunction remaining near the top of the cascade. This is logical and testable, reproducible, and fundamentally watertight in its assertions, meaning it works and back pain symptoms can be cured definitively if you cure the movement dysfunction disease that causes them. But this is a paradigm shift in thinking about the condition of back pain. This is a busy but very important and probably the most difficult concept to convey to non-medically trained people. It's critical to understanding that there are structural and functional diseases that may cause pain and disability. And I've given examples here, like a brain tumour versus depression, or emphysema versus asthma. These are two debilitating conditions of different organs. One has clear structural deficits and the other does not. In the musculoskeletal system, the massive majority of pain and disability symptoms arise gradually over time before significant structural changes predictably develop as a consequence of the primary functional disease of movement dysfunction. So you can see that there is a clear distinction between structural diseases and functional diseases. Dysfunctional movement biomechanics cause low-grade repetitive biological inflammation that hurts. And over years, that inflammation causes the structural changes that are visible on the MRI. For example, spinal stenosis, facet joint arthritis, annular tears of the disc prolapses, and structural instability. But you must remember that they are all downstream structural changes that develop as a consequence of the upstream functional movement disease. Remember the cause-focused disease model required for success. Imagine if we only throw solutions at the symptoms but ignore treating the movement dysfunction cause. How many of our listeners have ever heard of specific and distinctive functional movement therapy to cure the movement dysfunction? And functional movement therapy is none of those interventions that are displayed in that slide. None of those interventions which are commonly applied describes functional movement therapy. I know my patients are not receiving movement therapy because not one back pain patient that I've seen over the last 20 years has come to see me in my tertiary care setting having already endured countless hours of primary and secondary rehabilitation, has been able to describe even vaguely the definition of proficient movement of their lumbar spine, and that's the region of their body that is afflicted with chronic pain. understanding movement dysfunction is so important because it means that I don't have to resort to this futile advice that I hear over and over again from patients. The rehab therapist said that there's nothing more that they can do, so you better go and see the surgeon now. And the surgeon said, well, your spine's not bad enough yet for surgery. Stop doing all the activities that aggravate your pain and come back and see me in 5 years' time, and then I'll do a spinal fusion. Now, from the medico-legal perspective, it allows us to justify adequate compensation for severe pain and disability ascribable to a functional disease, even if the structural changes have not yet evolved. Remember, an MRI scan is not a functional pain scan. It is a structural snapshot. It does not provide any information about functionality. Here's a video of someone who has had countless rehabilitation sessions over a period of 6 to 12 months. He has a normal MRI scan, and it's clear that he has severe pain and disability, severe impairment, and has overt movement dysfunction that has been ignored from the outset. Now, his maximum impairment categorization would fall into a DRE category 2, and yet this guy has trouble putting his pants on. How do we reconcile this? Let's have think about a case example of a 25-year-old furniture removalist injures his back lifting at work. He has his initial 1 week off, and his boss thinks he'll get back to work, and he's still in a lot of pain, so he gets it extended for another 6 weeks. He goes on to taking some pain medication, resting up, and then gradually getting into some physiotherapy, guided rehabilitation, all the usual interventions, deep tissue release, manual therapy, progressing to some stretching and some low intensity couch-based, floor-based strengthening exercises. But of course, like so many other people, his symptoms do not improve to any valuable functional state, and so people get a bit concerned and do an MRI scan, and this is his MRI scan. Early disc signal changes indicative of degeneration, and a small high signal in the posterior disc annulus there at L4-5 that could be reflective of a annular tear. He sees a surgeon, no structural pathology to decompress, the nerves aren't squashed, so there's no point doing a decompression, and such a small high intensity zone on the MRI scan does not justify the major intervention of a spinal fusion or a disc replacement. So he's having diminishing returns with advanced and unvalidated pain intervention, blunderbuss approaches with epidurals, increasing potency analgesia. Some pain specialists will suggest medial branch block, radiofrequency neurotomy. Ongoing pain and disability progresses to chronicity well into the 6 to 12 month time frame, loss of livelihood, social interactions, and compromised mental health. Of course, he's going to fall into anxiety and depression. His life's been turned upside down from being a fit, active, strong a young man making productive and gainful employment in the furniture removal industry. Where to from here for this patient? What this really reflects is biomechanical stress causing inflammation and premature structural breakdown, or discitis, degeneritis, and potentially neuritis. It may have been pre-existing structurally, but it was not pre-existing functionally. This is what a typical clinical specialist report will describe. Not even a valid clinical diagnosis is offered in this document. remember, degeneration is normal. He wants the patient to begin a return to work program, even though he can't water his lawn and has failed 3 other attempts at returning to work. He's stating that the incapacity for employment has ceased. So here we have the AMA5 DRE table, the diagnosis related estimate table for lumbar spine impairment assessments. The first point is that there is no diagnosis mentioned at all. So the table itself is very poorly reflective of the pathomechanisms. It's not a diagnosis related estimate table at all. There is no diagnosis mentioned. It's just observations of varying structural alterations utilised to establish progressive percentages of impairment. Likewise, from the GEPI, or Guides to Evaluation of Permanent Impairment, further impairment is offered based on surgical structural history and observations, such as if the patient has had a decompression, a DRE3 category can be assigned. If the patient has had a fusion or an ankylosis there, a DRE category 4 can be assigned. In many cases, severe pain and disability exists without any of these structural changes, which leads to very low whole person impairments and consequently very low judgment of disability. The presence of functional impairment, not just structural impairment, must contribute to the overall whole person impairment, or if not, it must be emphasized and legitimized in the disability rating process, which is of course where the movement dysfunction clinical model comes into play. So here are 2 MRI scans. At the top, one patient, and at the bottom, the axial views show a normal spinal motion segment on the left, and on the right-hand side of that, the same motion segment with some structural changes reflective of degeneration, with a bit of a bulging disc and some enlarged facet joints or facet joint hypertrophy. Now, the individuals who own these scans could either be feeling perfectly normal or completely disabled with pain. The determinant is whether or not movement dysfunction is active. Now, let's read how expert opinion could vary dramatically depending on the old versus the critically required functional paradigm that I've been discussing. So, medico-legal interpretation 1, the structural changes represent pre-existing degeneration. There is no evidence of any clinically significant neural compression or spinal instability. There is no indication for surgery. The back pain symptoms have been treated with extensive rehabilitation. The condition is stable and stationary. There is no verifiable work-related injury. The changes observed on the MRI lumbar spine are entirely pre-existing whole person impairment 0. Medico-legal interpretation 2. A temporal and mechanistic relationship exists for the new presentation of severe pain and disability. Clinically, pain symptoms are severely restricting the biomechanics of normal proficient lumbar-pelvic movement. Rehabilitation performed to date has not reversed movement dysfunction. The imaging reflects changes of symptomatic biomechanical stress driving biological inflammation, and so transforming previously pain-free degeneration into painful degeneritis, discitis, neuritis, arthritis, which was not present prior to the injury. The condition is not stable and stationary. Okay, so same patient, 2 incredibly different reports. One based purely on the functional appearance, one based purely on the structural appearances, one based on the understanding that there is a functional cause for the pain and disability, and that the pre-existing degenerative changes are transformed into inflamed degenerative changes, which of course are painful. So the medico-legal key points. The respondent or insurer's defence of negligible liability and compensation rests on the absence of structural compromise on spinal imaging. This entirely ignores the fact that a consistent temporal and mechanistic event occurred resulting in pain. Structural injury is commonly beyond the resolution power of advanced imaging. Pain and disability does not show up on an MRI scan. Non-conjectural functional impairment contributes to disability. Pain, by definition, compromises movement proficiency. The quality of spinal motion segment movement is disturbed. The plaintiff now suffers from a functional disorder appropriately termed movement dysfunction, and this is easily definable and verifiable on clinical assessment if you know to look for it or if you're even thinking about it. In a vicious cyclic manner of rightfully compensable suffering, movement dysfunction continues to drive biomechanical stress within spinal joints, which drives further biological inflammation and nociception, perpetuating further pain, disability, and more movement dysfunction. Central pain can be added onto this, but this is an element of pain that I haven't discussed in detail. But it also plays a large role in poorly managed rehabilitation. If movement dysfunction is not appropriately reversed in a timely manner, additional layers of neurological central pain are layered on top of the primary structural musculoskeletal inflammatory and nociceptive pain. Even the most potent and best intended structure-focused rehabilitation, potent anti-inflammatories and analgesics will fail to resolve recurring inflammation, nociception, and neurologically driven central pain if the biomechanical movement dysfunction trigger is not effectively recognised and addressed. So in summary, connecting the disconnect, the existing system attributes disproportionately and incorrectly compensation based on the evidence of impairment based on structural compromise. In terms of pain and disability, the structural integrity is only associative, not causative. Functional biomechanical movement proficiency status of the spinal motion segments, however, are always causative or deterministic of either a healthy pain-free spine or inflamed, painful, disabled spine. The ability to distinguish, emphasize, and justify legal compensation rests upon the plaintiff or his team or his or her team understanding the movement dysfunction clinical model for the cause of low back pain symptoms and conveying this effectively to the judgment of disability. So thank you very much for that. I'd be happy to talk more to people about this important concept. And of course, if you have clients or patients suffering from low back pain, in particular requiring clinical input or assistance with their medico-legal claims, please feel free to get in contact with me on those contact details there. Thank you very much.